again to our bi-monthly spinal cord injury in-service lectures, joined today by Dr. O'Hanlon, who will be discussing lidocaine for autonomic dysfunction during a bowel program. With that, take it away.
All right, thanks, Dr. Abramoff. So as you said, yes, we're going to talk about lidocaine for AD that may be being caused by doing the bowel program in SCI patients. So to start off, I thought we'd go over what AD actually is and why this is such an important thing to care about. So basically, it's dysregulation of the autonomic nervous system that leads to an uncoordinated response that can result in potentially life-threatening hypertensive episodes, especially when there's a noxious stimulus that's occurring below the level of injury. So usually with our SCI patients, we'll see this with patients who have a T6 level or above. Usually it can be up to 90% of patients with cervical or upper thoracic injuries, and it's also more likely in patients who have complete injuries. For patients with injuries below T6, they have intact splanchnic innervation that allows for compensatory dilation of their splanchnic vascular bed, so then they don't see this hypertensive response. But basically what's happening is a noxious sensory input is occurring with the peripheral nerves that's happening below the level of injury. You then get this reflexive sympathetic response below the level of injury that's leading to vasoconstriction. Then the body tries to engage in parasympathetic response, but those impulses do not pass the injury level. So basically you end up with a parasympathetic activity above the injury, sympathetic activity below, and then this causes this increase in blood pressure. Usually we define it as more than 20. Sometimes I saw things saying up to 40 above baseline as well. And generally these patients have low blood pressure at baseline, maybe like 90s or 100 systolics. So for someone who's not familiar with autonomic dysreflexia, they may see a blood pressure of 130 or 140 and not think much of it. But for these patients, that can be AD. And then usually it's also accompanied by symptoms like headache, bradycardia, flushing, cold skin, sweating. So there's many potential causes. About 85% of the time, the cause is urological. So overfilled bladder, UTIs, bladder spasms, kidney or bladder stones. There's also many other possible causes, including bowel is the next up, then things like ulcers, appendicitis, gallstones, sexual activity, pressure ulcers, burns, ingrown toenails, blood clots, broken bones, anything that's like extreme temperatures, too tight clothing, belts, shoes, splints, anything that can provide a noxious stimuli can cause it. So I saw the 6 B's, if you like alliteration to remember things, about common causes of AD. So as we said, bladder. So if they have a Foley, the Foley. If they're getting cath, if they haven't been cathed in a while, now it's distended, the stones, infection, etc. Bowel. They said they call it back passage for rectal issues, anal abscesses or fissures, boils, so like I was saying, ulcers, bones if they have fractures, dislocations, and then babies is another big one with pregnancy. So for treating AD, the immediate first step is to sit the patient upright with their legs dangling. You want to remove any tight clothing or constrictive devices to help eliminate any triggers, and then also to help pooling of blood in the lower extremities. You want to evaluate the Foley. If they have one, make sure it's not kinked. If they're getting straight cathed, do straight cathing, the bowel program, as those are the most likely stimuluses. And then if that's still not working, you would want to look for these other causes like the skin lesions, infected toenails, ulcers, fractures, etc. Think about medication causes if that may be in effect. And then if you cannot identify the stimulus and these maneuvers are not improving and you're still having systolic blood pressure that's like 150 or like 40 above their baseline, and then you would want to start thinking about pharmacological management. So that would be the nitro 2% paste that you would do on their skin, maybe like their shoulders above the level of the injury. There's also other options like clonidine, nifedipine, that can be considered as well. So why do we want to be so aggressive about treating AD is that this sustained and severe hypertension can lead to many problems as the symptoms that we said before, but then also things like MI, renal failure, pulmonary edema, retinal hemorrhages, cerebral bleeds, strokes, death. And it is very dangerous for our spinal cord injury patients. Patients who have AD have a significantly higher death rate than similarly injured individuals who do not have episodes of AD. And having AD increases stroke risk by 300 to 400%. So that's why we want to be so aggressive in recognizing AD and treating it. So then getting into the bowel management in SCI, as we know, bowel dysfunction is very common and disabling following SCI and causes major restrictions on quality of life. Most patients use bowel management programs. These can vary from patient to patient and may depend on their SCI level and symptoms. Since we're talking about AD and all our patients that we're thinking about right now are all, really T6 or above. So we're thinking more hyperreflexic bowels and the bowel programs that go with that. So often suppositories are a common component of these bowel programs that patients do, usually combined with oral laxatives as well as digital bowel stimulation. So as we were saying before, urologic and bowel are some of the two most common causes of AD. But what has also been found is the bowel program itself can also cause episodes of AD. So I just found these two studies. Faaborg back in 2014 was looking at 8 Asia A patients who were T6 or above. All of these patients did have a history of AD, and they just measured their blood pressure following digital rectal evacuation, and found that all of these patients had a significantly increased systolic blood pressure from 127 to 188 which would significantly increase from their baseline. For Furusawa as well in 2007 also looked at similar things. They looked at the insertion of rectal medication and also found a significant increase in systolic blood pressure, and that this persisted from the rectal medication being inserted itself, as well as during the digital rectal stimulation, and then further evacuation. And it persisted until about 5 minutes after the final flow of stool ending. So that graph you can see on the side, that is just the blood pressure of one of the spinal cord patients they were looking at. And if you can read it, it's like the first digital stimulation is kind of it's the insertion of rectal medication is our first arrow to the left. You can see the little peak. And then once you get to the first digital stimulation and then manual removal of stools, that's where you're having all these different peaks, and you're peaking each time they attempted to manually remove stool. And then it kind of flattens out at the end. About 5 minutes after defecation is when you can see it starts to blood pressure stops kind of peaking as much, and then it seems pretty stable by the time you reach the end at 30 minutes of defecation. So the lines on here, it's systolic blood pressure is the highest, then diastolic blood pressure, and then that one that is remaining flat-ish around 50 is heart rate. This was just another graph that they took during this study that's just showing the changes in systolic blood pressure during the bowel program, and again, during each kind of maneuver that's happening with the rectal medication being inserted, digital stimulation occurring, and then manual removal of stool. And so we can just see there's a significant increase in blood pressure during the bowel program for these patients. So people have been, since we know that AD can be so dangerous and can lead to all sorts of complications, including stroke and death, the current guidelines have been advocating for lidocaine as a lubricant during bowel care, with the rationale that it's going to minimize the sensory stimulus and then reduce AD response to bowel care. So management guidelines have been recommending the use of lidocaine jelly for prevention of episodes of AD. So I found some that was saying that to use it for any urethral or anorectal irritation, so urinary catheterization, rectal examination, stool removal. And those have been guidelines that people have been trying to follow, it seems, but then There's also some contradictory evidence. So Lucci et al. In 21, they were looking at lidocaine lubricant 2%. If it's improving AD in at-home bowel regimen routines, they had 13 participants who were had spinal cord injuries with a C3 to T4 level. These patients performed their normal at-home care on 2 days, each using a different lubricant. So they were not necessarily performing the same routine, but it was their usual home routine for themselves. And basically what they found was that bowel care duration was increased with lidocaine, that it was about 79 minutes compared to the placebo, which was just a normal lubricant. I think they used KY, was 57.7 minutes. So that was a significantly increase in duration, and besides the increase in duration of time, that all these patients experienced AD on both days, whether they were using the lidocaine or whether they were using the placebo lubricant. But the patients with the lidocaine had higher maximum pressures at 214 versus placebo at 196. So not only were they higher, but they were higher for longer as well because the duration of the bowel care was increased. So basically what they were saying from this article was in their research was that at-home bowel care is a potent trigger for AD, but that their findings really contradicted any current recommendations for lidocaine use during bowel care because it results in longer care routines and an increased burden of AD. So they were theorizing that this may reflect an inadvertent effect on the afferent blockade on reflexive bowel emptying. So basically, it's making the body empty slower because we're blocking the reflexive emptying. And then this is leading to longer bowel care routines. So then you're having kind of like a greater amount of symptoms because it's lasting longer and then exacerbating the AD. So since I was kind of confused with current recommendations and then this article, I was looking for more evidence of what we should be telling our patients and what we should be doing. So I found this systematic review by Gray that was done in 2022 that was hoping to answer the questions of local analgesics effect in reducing AD in individuals with spinal cord injury. So they ultimately, when they were looking through everything, they only found 6 studies, and really only 4 are relevant to the question that I want us to think about today. The other 2 are urological procedures. So we can go over these. The first 2, they're talking not necessarily about the bowel program themselves, but more about anorectal procedures. So it's not, doesn't answer our specific question. But so the Lucci et al. From 2020 article was one of the ones they looked at. It's the one on the 4th from the bottom. And then Furusawa from 2009 also was looking at lidocaine during bowel routine. They were found supporting evidence for it, that they found the incidence of AD was lower for patients who are using lidocaine compared to placebo, and that the systolic blood pressure was less than placebo as well for patients who used lidocaine. They also looked at heart rate and didn't really find any differences. So basically, their article was supporting that lidocaine can reduce the severity of AD, but does not prevent it. And then the other 2, they were looking at procedures that were done, and they were kind of split, finding whether it prevented it or not. So basically, the conclusions that we took away from that, so they found 3 studies out of the total 6, with the other 2 being the uro procedures rather than bowel. 3 of the studies found that it did lower systolic blood pressure or AD incidence compared to placebo. 2 studies reported no difference, and then the 1 study reported that it actually may worsen. So they felt that the current guidelines that recommend the use of 2% lidocaine jelly are really kind of based on clinical consensus, and that really need more robust studies are needed to really back it up. And they felt that they really could not offer a clear conclusion regarding the use of lidocaine during these procedures. So here are some of the sources that we talked about. But my thoughts from, I think the systematic review is a little tricky because only 2 of the articles are really looking at exactly what we want to look at with bowel regimen and lidocaine, and the results are split. So unfortunately, I'm not sure if I have a good recommendation for you guys either, but that's where we're at with the most recent data, I would say. And I think that's sources.
Great, thank you. Any questions from the audience? So I have a question. So I think you kind of said you're not sure, but if you have a patient on acute care who's having dysreflexia with the bowel program, significant dysreflexia, would you try lidocaine?
I mean, I think I would try it. Like I think like, you know, the kind of the, like, I think it's like Paralyzed Veterans of America, like their guidelines are still saying to use it. So I think I would be okay with trying it, but I think I would also want to follow up with the patient themselves about it, like, are they experiencing more or less AD symptoms? Maybe if we could try to get like a blood pressure and compare, if that's something that was like possible in the circumstances, just to make sure we were not making things worse. Because I think ideally, like if like the patient was reporting their symptoms were worse with it, like I would not want to use it. Or if, let's say, you know, we decided to do our own little trial with them, with just the one person, and had them take their blood pressure when they were doing it, and if we didn't notice a difference. But I think the mechanism that Lucci and colleagues found like kind of makes sense of when, like, if lidocaine were to just extend the bowel program, and if people are getting AD whether they're using lidocaine or not, which I think other studies had supported, then I feel like it could make sense that you're having AD for longer, and that would be an overall negative.
Great. Any other ways that you think of to like decrease autonomic dysreflexia during bowel programs?
Well, I think like doing them, I guess that this wouldn't be like you would want to do them on a schedule, because I know like our guy upstairs, like he has issues doing it. So I think that would be more in general. During the bowel program itself, I mean, I don't know if like you could do like if like any oral like pain control would be helpful. I didn't like see anything about that when I was like looking into this. But I wonder if like that would be something useful. But I imagine just like ensuring that you're kind of like have like good positioning and doing it kind of like properly. I know like you want to avoid like manual evacuation when possible, because that seemed to be the worst of it. Like the suppository itself like didn't cause as big peaks in some of the studies as like actual manual evacuation. So I feel like avoiding that if
So
like
most patients will need some sort of digital stimulation in order to empty their bowels completely. And I think you make a good point, like making sure that they're like not positioned in a way or sitting on like a hard commode for a long period of time, if they're doing it like independently, or making sure they're appropriately cushioned. If they're doing it on their side, I think those are really good points. Making sure the stool's not like too hard and that you're not like having to like breaks are going too infrequently. I think counterintuitively, you know, depending on the person, doing it more frequently may be helpful to prevent, you know, severe constipation and having to really disimpact and do for, again, prolonged periods of time. So I think, you know, doing it regularly, keeping the stool a little bit on the softer side for our upper motor neuron bowel programs that are the ones who are likely to have dysreflexia, I think is a really key component. Making sure their skin, you know, there's no skin breakdown or anything. What if a patient is having like severe, like dangerous dysreflexia, you know, every time they do a bowel program?
I think you'd want to maybe think about like other stool options like ostomies or something, because I did see like case reports about patients who died during bowel programs.
Yeah.
So I think if like the alternative is death, like an ostomy would probably be better.
Yeah, I think for some patients, for a lot of reasons, but certainly if they're having severe painful headaches and this reflects every time they do a bowel program, I think that would add into the consideration. So very good. Thank you, Dr. O'Hanlon. As always, these lectures will be available on the YouTube page for review, and I appreciate you giving us a great lecture.
All right, thank you.
Thank you.